Hi, everyone. My name's Heather Hampel. I'm a cancer genetic counselor at The Ohio State University, and I'm so pleased to be talking to you today about cancer risks, screening, and prevention for people with Lynch syndrome. Lynch syndrome is the most common inherited form of both colorectal and uterine or endometrial cancer. And it's caused by inherited mutations in one of the 4 genes you see here on the screen. MSH2 and 6 are on chromosome 2, MLH1 on chromosome 3, PMS2 is on chromosome 7, and there's a 5th gene, EPCAM, that's right in front of MSH2 and causes Lynch syndrome essentially by turning off MSH2. These genes are known as the DNA mismatch repair genes, and when they're not working properly, it causes Lynch syndrome. So studies have now estimated that 1 out of about every 279 individuals has Lynch syndrome, making it one of the most common inherited conditions in the world. And if you take that times the population of the United States, that means there are over 1.2 million people in the US who have Lynch syndrome today. As I mentioned, this is an inherited condition that causes high risk for colorectal endometrial cancer, but it also causes high risk for ovarian, gastric or stomach cancer, and several other cancers. Luckily, the main cancers, colorectal, endometrial, and ovarian, are preventable with earlier and more frequent screening or risk-reducing surgery. So what's the problem? The problem is that we currently estimate that 95% of individuals with Lynch syndrome are not aware of their diagnosis. So they're not able to benefit from all of these screening and prevention options that can keep them from getting a cancer or catch it early when it's treatable. So we're doing lots of efforts to try and identify more individuals with Lynch syndrome, but in the meanwhile, there are good estimates of the cancer risk for individuals with Lynch syndrome and recommendations for screening. And I will take these from the National Comprehensive Cancer Network, most recent guidelines from 2021. So they split out last year the cancer risk by gene because they do vary pretty widely by gene. So looking at MLH1 cancer risk, MLH1 is one of the higher risk Lynch syndrome genes. You can see that the risk for colon cancer ranges from 46 to 61%. And this is compared to 4% in the general population. So at least a 10-fold increased risk in the colon cancer risk. And the average age of diagnosis is 44. For endometrial cancer, the lifetime risk is anywhere from 34% to 54%. And again, the general population risk is only 3%. So at least a 10-fold increased risk for endometrial cancer as well, with a slightly later average age of diagnosis than colon cancer at 49. The third most common cancer is arguably ovarian cancer with a 4 to 20% lifetime risk compared to 1.3% in the general population. So this is at least sort of triple or quadruple the general population risk. And again, with an average age of diagnosis in the 40s. And then you'll see some of the many other cancers that have been associated with Lynch syndrome, but all of them are at relatively low risk. The only 2 with higher risk are prostate cancer and breast cancer, and that's just because they're very common in the general population. So the general population has a 12 or 13% lifetime risk for getting these cancers. So it's not even clear that it's significantly elevated in an individual with Lynch syndrome. So this is somewhat controversial whether there's increased risk for those 2 cancers, particularly with MLH1. And the screening really does focus on the colon, endometrial, and ovarian cancer, but we also consider screening for the stomach cancer, the pancreatic cancer, and the urinary tract cancers, really depending on the patient's family history more than anything, and some other risk factors. So looking at MSH2 cancer risks, the colon cancer risk with MSH2 are 33 to 52%, and again, compared to 4% in the general population. So, approximately 10-fold increased risk is going to be right in the middle of that range with an average age of diagnosis of 44 again. The endometrial cancer risk ranges from 21 up to 57%. So big range there, significantly elevated in the average age of diagnosis, just a little later in the 40s. The ovarian cancer risk with MSH2 is at a quite young average age of presentation, 43, and the risk ranges from 8 to 38%. And then again, you see a long list of other cancers, but notably the urinary tract cancers seem to be quite high in particularly males with MSH2 mutations. So there you're seeing this 28% here. So this is something that for MSH2, some people do consider screening for the urinary tract cancers, which tend to happen in the renal pelvis. Those are the collecting ducts in the kidneys, and the ureters, which are the tubes that take our urine from our kidneys down to the bladder. And then of course, bladder as well. So these are kind of all considered urinary tract cancers, and it's significantly elevated with MSH2. And again here, typically when you see an elevated prostate cancer risk with Lynch syndrome, it surrounds the MSH2 gene again. So you can see it's up to a 24%. Now it's still crossing the general population risk. So again, this is not entirely clear yet, but multiple studies have shown an elevated risk for prostate cancer in men with MSH2 mutations. So now moving to the two lower risk Lynch syndrome genes. So with MSH6, the colon cancer risk is somewhere between 10 and 44% lifetime compared to 4% in the general population. So anywhere from 2.5 to 4-fold increase, with an average age anywhere from 42 to 69. So quite variable. The endometrial cancer risk still quite elevated with this gene at 16 to 49%. The little later age of diagnosis, we're now in the 50s as opposed to the 40s with the other two genes. Ovarian cancer risk, just slightly elevated at somewhere between a 1 and 13% lifetime risk compared to the 1.3 in the general population. And we don't see a very high risk of any of the other cancers with the MSH6 gene. So again, here, just screening if those cancers have been seen in the family history. And PMS2 may be the most controversial of the Lynch syndrome genes and probably the lowest cancer risks. And here you can see anywhere from an 8.7 to 20% lifetime risk for colon cancer compared to the 4%. So double, 2 to 5-fold increase. So significantly lower than with MLH1 and MSH2 with a much later average age of diagnosis in the 60s. The endometrial cancer risk somewhere between 13 and 26%. So elevated, but not nearly as high as with the two high-risk genes. And again, a closer to 50-year average age of diagnosis. The ovarian cancer risk is actually not been shown to be significantly increased. And so this has changed some of the management guidelines for PMS2 in the last year or two, where, with this gene, maybe women do not need to consider hysterectomy or need to think about it a little bit more because there are certainly risks and side effects of the procedure, and the benefits may be lower with this lower risk for ovarian cancer. And then, as you can imagine, all of the other cancers are really not significantly elevated. So it's questionable whether to screen for any of the other cancers. And again, it's kind of just based on whether they've been seen in the family or not. I should mention the EPCAM risks are considered to be basically the same as MSH2 cancer risks, but they do seem to be a little bit more specific to colon cancer. So what is the surveillance, the screening recommendations for individuals with Lynch syndrome? So they also offer these by gene, but I've just combined them into one table so that we don't have to go through 4 tables for each of the genes, and kind of highlighted where they differ. So the colon cancer risk, the big difference is that for the two high-risk genes, they recommend that colonoscopies start at age 20 to 25 and repeat every 1 to 2 years. And there's always this caveat that if there's a really young case in the family, we need to make sure we're at least 2 to 5 years younger than that. So say there's a family member who had colon cancer at 21, we're going to need to start that family screening anywhere between 16 and 19, 2 to 5 years earlier than that earliest diagnosis in the family. So a little bit earlier than the 20 to 25. Now, the 2 lower risk Lynch syndrome genes, MSH6 and PMS2, start a full decade later. So they start between ages 30 and 35 and still repeat every 1 to 2 years. And they also have the same caveat that if there's a particularly young diagnosis in the family, we need to be at least 2 to 5 years prior to that. So that's one of the biggest differences right now, is the later start age for colonoscopy, depending on whether you have a mutation in one of the high-risk Lynch syndrome genes or one of the lower-risk Lynch syndrome genes. And you saw that the average ages of diagnosis were much later. And so it appears that even starting a decade later is early enough for most patients with mutations in these 2 genes. Now, for endometrial cancer, uterine cancer, typically what we recommend is education regarding symptoms, because this tends to get diagnosed quickly based on irregular bleeding symptoms. So bleeding between cycles or after menopause, bring to the attention of the doctor right away, OBGYN, and they will evaluate you. There are screening recommendations. You can do an endometrial biopsy every 1 to 2 years, starting at age 30 to 35. There's pretty good data that this actually catches endometrial cancers early, but there's no data that it actually improves outcomes, because endometrial cancers tend to get diagnosed early anyway, and people do well. So it's controversial whether to bother with the screening when it doesn't change the overall outcome. And then, of course, the consideration of a hysterectomy after someone's done with childbearing is there as well. And at least one study of hysterectomies risk reducing in people with Lynch syndrome showed essentially no risk for uterine cancers after hysterectomy. So it was very, very good at preventing endometrial cancer. Now, ovarian cancer, similarly, they do education regarding symptoms, but they're a lot more vague and harder to pick up. So, bloating, backache, fatigue, those kinds of things that are a little harder to kind of pinpoint as being something different from the ordinary. So they can also do a transvaginal ultrasound and CA125 screening, similar to our BRCA1 and 2 positive women. But as we know, there's really no evidence that that is very effective. So it ends up with a sort of similar situation that removing the ovaries and fallopian tubes after childbearing is the most secure way to lower the risk of getting ovarian cancer. And then this dovetails into the whole situation with PMS2 not having really a proven increased risk for ovarian cancer. And so with PMS2, a little less of a push towards a hysterectomy and a bilateral salpingo oophorectomy than with the other Lynch syndrome genes. And this is just starting to shake itself out, but it certainly makes things, a little bit complicated for our patients with PMS2 mutations as they try to decide what to do. The stomach cancer risks and small bowel cancer risks, there are risk factors like male gender, older age, MLH1 or MSH2 mutations, a first-degree relative with stomach cancer, Asian ancestry, and then some stomach problems like chronic autoimmune gastritis, gastric intestinal metaplasia, or gastric adenomas. So the current guidelines are to do an endoscopic, an upper GI endoscopy or an AGD with a random biopsy of the proximal and distal stomach to check for H. pylori, to check for that autoimmune gastritis and the intestinal metaplasia beginning at age 40. And then if somebody has any of those risk factors, they repeat it every 3 to 5 years. If they don't have any of those risk factors, so there's no family history, they're not of Asian ancestry, and they did not have any findings on their baseline EGD, then they do not need to repeat the upper scope. And so this is a really tailored one based on what's going on in somebody's family, what's going on in their stomach, and what their ethnicity is. So then urinary tract cancers. So there's no clear evidence to actually support this screening. So they're really kind of targeting individuals who have a family history of urinary tract cancers, and particularly, as I mentioned before, MSH2 mutation carriers, especially males. And so what they're recommending is an annual urinalysis, and that's really just to check for your blood in the urine. And that starts annually at age 30 to 35. But there have been some studies looking at it and urine cytology, the biggest one out of the Netherlands, where it did catch some urinary tract cancers early, but it missed as many as it caught. And so it didn't really look very effective. On the other hand, it's inexpensive and non-invasive to give a urine sample. And so I think that's why it's been kept, but not a lot of data that it's super effective. And so there are people very interested, particularly for men with MSH2 mutations, and should we be doing ultrasounds or something in addition to try and screen for those urinary tract cancers. Now, pancreatic cancer, luckily last year or the year before, was included in an update to the hereditary breast, ovarian, pancreas NCCN guidelines. And so the colon guidelines defer to those. And it basically says that if somebody's got Lynch syndrome and has a relative with pancreatic cancer, they should consider pancreatic cancer screening beginning at age 50 or 10 years prior to the earliest diagnosis in the family. And they usually use an endoscopic ultrasound or a contrast enhanced MRI or MRCP. And so they kind of will alternate sometimes between those, and it's once a year. And if they see something that's concerning, they might shorten up those intervals and do them more often than annually. And then they just note that there's a lot of cystic lesions in the pancreas, and most of them won't warrant a biopsy or a resection or any intervention at all. So this is something that patients who start doing need to be aware of, because it can be scary to be screening for this and to see something that you just are going to watch and wait. At this time, because of no strong evidence of an increased risk for prostate cancer, and really the main evidence being in MSH2, there's no evidence of earlier ages of diagnosis. The current recommendation is general population screening for prostate cancer. Same with breast cancer, general population screening for breast cancer. If there is a slight increased risk, it's not any earlier, and so general population screening appears to be sufficient. There is a slight increased risk for brain cancer, specifically glioblastomas with Lynch syndrome, but they just say there's not really a screening for that. But when someone's getting a physical annually, they can assess for neurological symptoms, check the reflexes, that sort of thing. So that should be done once a year starting in the 20s, like everybody with an annual physical. And then, of course, we always talk about reproductive risks. So advising people about options for prenatal diagnosis, pre-implantation genetic testing, if they would prefer not to pass on the Lynch syndrome mutation that's running in their family. And there is a rare recessive condition if two people who both have Lynch syndrome due to mutations in the same Lynch syndrome gene have children together. There's a 25% chance with each pregnancy that the child would inherit both mutations and have the more severe condition called constitutional mismatch repair deficiency, which can have childhood hematologic malignancies and brain tumors, and then earlier onset Lynch syndrome cancer. So it's a much more severe condition. And so we certainly let any of our patients with Lynch syndrome who are childbearing age know about that risk. Okay, so just to dig in a little bit deeper on managing the colon cancer risks with Lynch syndrome, the colonoscopies, again, we talked about starting in the 20s to 25. Preventative surgery like a colectomy is a consideration, but for select patients with Lynch syndrome, if there are people who can't be compliant with the screening recommendation, they can't get their colonoscopy every 1 to 2 years, or prefer not to do their colonoscopies every 1 to 2 years. If people got colon cancer already in 2 different areas of their colon, they're probably going to remove the whole colon. If they've got polyps that aren't really amenable to routine colonoscopy and removal of the polyps, like too many of them or in difficult places, and if people have, multiple diffuse or very small polyps with high-grade dysplasia, that might be an indication to remove the colon as opposed to doing screening. And just in, contrast, the general population starts their colonoscopies now at age 45 and goes every 10 years. And so that's the contrast. But certainly anybody who, if you don't have Lynch syndrome and have a family history, you start at 40. African Americans who have a higher risk have been supposed to start at 45 for many years now. And people who have a close relative with an advanced polyp start at 40. So there's lots of reasons that some people might need to start their colonoscopies earlier, but with Lynch syndrome, it's 20 to 25 or 30 to 35 in every 1 to 2 years. There is a reason that we do the colonoscopies more closely together with Lynch syndrome, and that's because it takes less time for a precancerous polyp or an adenoma to become a cancer in an individual with Lynch syndrome than it does in the general population. So in the general population, it takes about 10 years for an adenoma to become a colon cancer. That's why we can do our colonoscopies once every 10 years in the general population, because if you don't have any polyps at 50, you should not have a cancer anytime in the next 10 years. The average dwell time of an adenoma in Lynch syndrome is 3 years. So it only takes on average about 3 years for an adenoma polyp to become a colon cancer. As a result, we have to do the colonoscopies much more frequently because we want to remove them while they're still a polyp and before they become a cancer. And this is why we recommend every 1 to 2 years. I always tell my patients with Lynch syndrome, you may go 10 times in a row if you start at 20 and not have any polyps. And you're going to be thinking, oh, this is crazy. I'm going to skip a few years. But you really can't, because the polyps can become cancer so much more quickly. You really got to keep to that 1 to 2 year frequency. So there's the 33 months, or about 3 years average time for an adenoma to become a colon cancer. We know that the colonoscopy is extremely effective in patients with Lynch syndrome. In this sort of famous study from Finland, people with Lynch syndrome were offered colonoscopy every 3 years, and half of them did it and half of them didn't. So they sort of randomized themselves. In the group that was doing screening, there were 8 colon cancers, but that compared to 19 in the group that was not doing screening. And most importantly, in the group that was screening, no one died from their colon cancer, whereas 9 of the individuals in the group that was not screening died from their colon cancer. So this is a 65% reduction in colon cancer incidence at every 3 years, and no deaths from colon cancer at colonoscopy every 3 years. So again, this kind of fed into the recommendation, well, we'd like to prevent these 8 in the first place. Why don't we go every 1 to 2 years? The controversy at this point about the length of time between colonoscopies has to do with the fact that they think there's been a recent study that found it doesn't matter how long it's been since the last colonoscopy. We didn't see that the cancers were higher stage if someone had been taken longer between their colonoscopies. And so there is this theory that there's 3 ways to get a colon cancer in a patient with Lynch syndrome. 2 of them go through an adenoma, which would be prevented from frequent colonoscopy, but the 3rd doesn't. It goes from a mismatch repair deficient crypt straight to a colon cancer. And so these don't have that intermediary adenoma and could be missed even if we were doing colonoscopy very frequently. And so this is some work out of Europe that we're keeping a close eye on, and can explain why some people even doing very frequent colonoscopies with Lynch syndrome may still get a colon cancer. They've looked at different techniques, and they really found that using dye during the colonoscopy doesn't improve it much over using normal white light endoscopy. And so at this point, we don't use the dye or chromo endoscopy with our Lynch syndrome patients. And this is just showing that the average number of adenomas is the same, no matter which mechanism was used. We now know for prevention that aspirin is extremely effective at lowering the risk for colon cancer. And this is from work done in England with John Byrne. And even the general population, the US Preventive Services Task Force now recommends a baby aspirin for all adults ages 50 to 59 for primary colon cancer prevention and for cardiovascular disease prevention. So we know aspirin, even in the general population, reduces the risk for colon cancer. But in the CAP2 study, they found that it actually significantly reduced the risk of colon cancer in individuals with Lynch syndrome. Of course, they were using a much higher dose. It was 2 adult tablets in England, which is about 600 milligrams a day. So at 4 years follow-up, those who had taken the aspirin for at least 2 years experienced a reduction in their colon cancer risk. They were about 63% less likely to get colon cancer. And it looked like they were less likely to get other cancers as well, but that was not statistically significant. There has been a follow-up study this year which confirmed the reduced risk for colon cancer at long-term follow-up, but does not appear that the aspirin decreases the risk for any of the other Lynch syndrome cancers on longer-term follow-up. So there is a CAP3 study going on right now to figure out what's the optimal dose. Is a baby aspirin enough? One adult tablet at 325 milligrams, or two in the US, which would be 650 milligrams. And the optimal duration too. It did look like for the first study that you needed to take it for at least 2 years, and then you didn't really start to see the benefit until 4 years after you'd started taking it. So they're clearing up those things. I find that most people in the US are recommending either one baby aspirin or one adult aspirin. And the concern is too much aspirin can lead to some side effects and bleeding. And too little may not be enough and to get that colon cancer risk reduction. So trying to find that sweet spot is the trick. This is that 10-year follow-up, and the bottom line is that you need to treat 24 Lynch syndrome patients with aspirin to prevent one colon cancer. And that reduction has persisted over a 20-year period, which is really exciting. It just did not seem to reduce the risk for non-colon cancers after that second decade. There's the graphs on that. So CAP3 is ongoing, and we'll be back in touch once we have the results of that. There are several chemo prevention studies currently recruiting in clinicaltrials.gov, and I would encourage you to check that out if you're interested in finding other studies. I'll just talk about a couple of them briefly here. This is atorvastatin plus or minus aspirin in Lynch syndrome. It's open at the Fox Chase Cancer Center. Their goal is 46 participants with Lynch syndrome. One group receives atorvastatin and the other group receives atorvastatin and aspirin. And they're looking at proliferation, cell death, and IHC changes from baseline to 6 weeks, and some other genetic testing and RNA testing from baseline to 6 weeks. And the secondary outcome is going to be whether people can take it. Are there any adverse events, and how acceptable is it? So this is a statin that has some evidence it might reduce the risk for colon cancer. This is a study of naproxen, so another NSAID that has some evidence in animals that it may be more effective than aspirin as chemo prevention for colon cancer. And so there's been some work done on this from Eduardo Villar at MD Anderson. He did a phase 1b placebo-controlled randomized clinical trial of 2 different doses of naproxen daily for 6 months with 80 participants who had Lynch syndrome. It was tolerated really well. And a lot of the early signs showed reduced inflammation, which is a good surrogate that it might lower the risk for colon cancer. And it seemed to, and they had a kind of co-clinical trial with mice. It just demonstrated robust chemo prevention activity. So people are pretty excited about the possibility of using naproxen for chemo prevention. And this is just the various arms. And the only arm that had any side effects at all was the high dose naproxen arm. And just to show that all of these prostaglandins decreased quite a bit in the patients that were on naproxen compared to the placebo arm. This is a study of omega-3 fatty acids in Lynch syndrome at the University of Kansas with a goal of 34 participants. And they will give omega-3 fatty acids orally once per day for a year. And their primary outcome is retention rate. And again, with the idea of decreasing the risk, hopefully, for colon cancer. And just briefly, you've probably heard all of the excitement about MMR deficient tumors being really responsive to immunotherapy. We've known for years that cancers from people with Lynch syndrome have a lot of tumor infiltrating lymphocytes. They were very active with immune system. They have a higher mutation burden, and they make these truncated proteins called frame shift protein peptides that are seen as foreign to the body. And so the body mounts an immune response. So knowing that these tumors had high mutation burdens, were MSI, and had all these tumor infiltrating lymphocytes, they were a good candidate for immunotherapy. And we all by now know the famous study showing that immunotherapy, in this case, was one of the early drugs, led to partial responses and complete responses in MMR deficient colon cancer and non-colon cancers, and does not seem to work in MMR proficient tumors. So this has led to a great treatment option for Lynch syndrome patients using immunotherapy. And the FDA has now approved immunotherapy for any MMR deficient solid tumor, which is really exciting. But there have been some studies now, the idea of using immunotherapy for chemo prevention. So there was a study we had started at OSU with Dr. Jeter, who's now at Huntsman, where we were going to try and use immunotherapy for chemo prevention in people with Lynch syndrome who had had a prior colon cancer and a partial colon resection. Unfortunately, the study had ended prematurely when the pharmaceutical company's priorities changed and they pulled the use of the drug. Anecdotally, one of the patients who received the drug did develop several non-melanoma skin cancers after their first dose. So there could be some side effects of doing immunotherapy for chemo prevention. And there is a study now open in China using immunotherapy for chemo prevention as well, in very similar MLH1 or MSH2 mutation carriers who had a prior colon cancer and a partial resection. So hopefully they'll get to pull off that study and we'll get to see the outcomes. And then maybe most excitingly, targeting those frameshift peptides with a vaccine is a very, very hot new area for Lynch syndrome. And there has been studies, Matthias Klor is leading these efforts, of 3 cycles of 4 subcutaneous vaccinations using those frameshift protein peptides, neoantigens mixed with something else for 6 months. And it did look like the vaccine induced humoral and cellular immune responses in all of the patients. 3 did develop pretty significant local injection reactions. There were no severe adverse events. And 1 heavily pretreated patient who did have bulky metastases showed stable disease and a stable CEA level over 7 months. So everyone is very excited about the possibility of a vaccine specifically targeting the frameshift peptides for our Lynch syndrome patients. So stay tuned for studies opening for this in the US. And this is just showing the frameshift peptides they chose are present in most of the cancers in individuals with Lynch syndrome and did induce a strong immune response. And there's not a lot of options for management or prevention of the other Lynch syndrome risks. Guidelines are, again, only guidelines. And so we really have to tailor things based on personal and family history and everyone's best clinical judgment. You know, particularly for these gynecologic cancers, gastric cancers, and skin cancers. There was one study looking at prevention of endometrial and ovarian cancers. Obviously, we know that the TAH-BSO may reduce those risks, but it's unclear if it changes outcomes, particularly in PMS2, where there's no evidence of a significantly increased risk. But here's the study showing that after hysterectomy, there was essentially no endometrial cancers in individuals with Lynch syndrome and no ovarian cancers in women with Lynch syndrome. One chemo prevention study looking at Depo-Provera and oral contraceptives for 3 months in women with Lynch syndrome who got an endometrial biopsy and ultrasound before and after their treatment showed significantly decreased endometrial proliferation with the use of oral contraceptives and or Depo-Provera. So it looks like they may decrease proliferation and lower the risk potentially for endometrial cancer. And here you can see the proliferation dropped significantly pre to post in the Depo and pre to post in the oral contraceptives. And as I mentioned, not much data regarding screening and prevention for other cancers. There's a CAPS-5 study open in the US for anyone with Lynch syndrome for pancreatic cancer screening. And that's about it. So in conclusion, Lynch syndrome cancer risk and screening and prevention guidelines are evolving over time as we gain more information. Cancer risks are lower in individuals following screening and prevention options, which is why the newer studies are showing lower cancer risks. And it's important to stay in touch with your genetics team to ensure that you're following the most up-to-date surveillance guidelines and that you have access to these upcoming screening and prevention studies that are very exciting. For example, the vaccine study. Thank you very much.